अस्सलाम वालेकुम डियर स्टूडेंट्स। आज हम स्लैब रीजन डिस्कस करेंगे। स्लैब रीजन के बारे में हम बात करें। So the objective of the today lecture are the students will be able at the end of the lecture to define slab region, what slab stand for. Similarly, students will be also able to describe the classification, etiology, epidemiology, and the pathoanatomy as well as the pathophysiology of the slab region. At the end of the lecture, student will also be able to differentiate different sublevel variation, what are the different types of the sublevel lesions. So they will be able to describe the sublevel lesion variations. They will be known to the histopathology of the slab lesion, and they will be also able to describe the history and physical examination maneuver of slab. At the end of the lecture, the student will be also able to describe some special tests that will be known to the maneuver, that will be known to the procedure, which can be used in that comprehensive thorough examination of the lesions surrounding the slab in the shoulder. Students will be also able to differentiate the slab lesion from the other nearby surrounding neighborhood lesions in the shoulder region. They will be able to describe the physical therapy and surgical management of slab lesions. The next objective is to describe the prognosis of the slab lesion and to describe the complications of the slab lesion. At the end of the lecture, we will discuss what is the post-operative rehabilitation of slab lesion. So the students will be able to formulate the post-operative rehab protocol for the slab lesions. तो सबसे पहले हम बात करते हैं कि स्लैब लीजन क्या है, स्लैब जो है इसकी एब्रिविएशन क्या है और इसको जो है इसकी हिस्ट्री पर थोड़ी सी बात करेंगे। तो स्लैब पे है दिस इज द सुपीरियर लेबरल इंटीरियर टू पोस्टीरियर लीजन और ये शोल्डर पैथोलॉजी में से एक वेल नोन और कॉमन पैथोलॉजी है और स्पेसिफिकली जो ये पुअर हेड एथलीट्स में ज्यादा होती हैं या एज यंग लेबर्स में भी होती हैं। इसके अलावा जो मिडिल एज मैनुअल लेबरर्स में भी हो सकती हैं, but mostly the overhead athletes they are very prone toward this lesion and sometimes बहुत सारे ऐसी एथलीट्स होंगे जिसमें बगैर कोई सिम्टम यानी they have the lesion, the slab lesion without any symptom. They are asymptomatic, but still the medical imaging will reveal that the person is having the athlete is having the slab lesion in the one of the shoulder on the right side or on the left side. So somehow we can also say that this is a functional adaptation. This may be a functional adaptation in those overhead athletes, specifically in the baseball pitchers. In 1985, the Andrews first described the superior labral pathologies, and then the Snyder et al. Later coined the term slab lesion. And this slab region was just termed just because of its location at characteristic tier, which is the location of the superior labrum, and the characteristic of this tier is from 10 o'clock to 2 o'clock position. That's why it is interior posterior tier of the superior labrum. So this is the healthy labrum. This is the 6 o'clock position. This is the 12 o'clock position. And this is the 3 o'clock position, the 9 o'clock position. This is the interior posterior tail, which is almost from the that. This is the 9 o'clock position. So more beyond the 9, mostly it is from the 10 o'clock position to the 2 o'clock position. So that here in this labrum, that is called as the slab region. This is the superior labrum, and the characteristic extension of this lesion is from posterior to the interior. So the tear is in both the superior interior quadrant and the posterior superior quadrant. So that's why it is the term slave lesion was coined for this lesion. स्नाइडर ने इसकी क्लासिफिकेशन जब की थी तो 4 सब टाइप डिस्कस की, लेकिन लेटर ऑन जो है कुछ रिसर्चर्स ने, कुछ बायोमैकेनिकल एक्सपर्ट्स ने इसकी फर्दर जो है टाइप डिस्कस की है। किसी ने इसकी सब सब टाइप्स की, तो किसी ने 8 टाइप्स इसकी क्लासिफाई की है। इनिशियली सबसे पहले जो है इसकी क्लासिफिकेशन डिस्कस की दैट वाज। तो ये 4 क्लासिफिकेशन किस तरह है, इसमें से टाइप 1 जो है दैट इज द least severe and simple, there is only the degenerated condition and there is no such damage, no such detachment of the that bicep. It means the bicep tendon is intact, उनकी जो पेरिफेरल अटैचमेंट होती है इनटू द दैट लेब्रम या जगह पर होती है, सिंपल वहां पे डिजेनरेटेड होती है और बाकी डिजेनरेशन के अलावा जो है, और ये एक नॉर्मल सा फिजियोलॉजिकली बहुत सारे एथलीट्स में ये प्रेजेंट होती है। टाइप टाइप 2 थोड़ा सा जो है यहाँ पे ये ट्रॉमेटिक टाइप भी हो सकती है, एज वेल एज यहाँ पे फीडबैक मैकेनिज्म हो सकती है, जहाँ पे इस डिजेनरेशन के साथ साथ जो है जो सुपीरियर लेब्रम पर बाइसेप टेंडन है, तो बाइसेप टेंडन और साथ इसके साथ सुपीरियर लेब्रम जो है, ये दोनों अपनी जो ग्रेनाइट रिम है उससे ये डिटैच हो जाते हैं। तो इट मीन टाइप 1 की एक्सटेंशन जो है दैट इज द टाइप 2। केविन डिजेनरेशन तो होती है ऑलरेडी, लेकिन उसमें जब जो superior labrum is attached on the granite rim or this long head of the bicep tendon, this is blended with the other that capsule and on the labrum. So जब इनकी डिटेचमेंट होती है, इनकी एवल्जन हो जाती है इस long head of the bicep tendon as well as the superior labrum, so this type of lesion will be termed as the type 2 slave lesion. Type 3 lesion, sometimes also known as the bucket handle tear of the superior labrum, and इसमें भी जो है वहाँ पे जो बाइसेप लॉन्ग टेंडन होता है वो इंटैक्ट होता है। लेब्रम जो है ये सिर्फ एक बकेट हैंडल की तरह लेजन में आ जाता है। सो इट मीन उसकी जो डीजनरेशन है वो थोड़ी सी जो सिवियर हो जाती है और लेब्रम जो है ये डिटेच हो जाता है और ये एक बकेट हैंडल की तरह जो है बन जाते हैं। जस्ट लाइक वी कैन सी हियर इन दिस diagram. Here this is the labrum, this surrounding this is the total labrum, this is the articular cartilage of the granite cavity. So यहाँ पे this is the tendon. The tendon is intact but the superior labrum जो है इसकी detachment हो जाती है and it hang like the handle of the bucket, just like we can assume that this granite cavity is a bucket and this is its handle. So that's why this type 3 lesion is known as the bucket handle tear. So which type of slave lesion according to Snyder is known as the bucket handle? This is the type 1, type 2, type 3 and type 4. So obviously the type 3 is known as the bucket handle tear or the bucket handle lesion. Then the type 4 is the extension of the type 3. There is the bucket handle tear. There is the bucket handle lesion as well as there is detachment and avulsion of the bicep tendon. So in type 3, bucket handle without the detachment of the bicep. In type 4, this is the bucket handle lesion along with the bicep tendon. रूट की जो extension है इस tear की ये हो जाती है towards the tendon. तो ये 4 types, type 1 and type 3 दोनों में जो है bicep tendon जो है ये intact रहता है, while in type 2 and type 3 there is detachment of both the tendon and the superior labrum. So and the type 1 there is only degeneration, in the type 2 there is degeneration as well as the detachment of the tendon. In type 3, this is bucket handle without the involvement of the detachment of the long head of the bicep tendon, while in the type 4, there is both the bucket handle lesion as well as the detachment involvement of the long head of the bicep tendon. So these were the four types classification by the Snyder. आने वाले डिकेड्स में बाकी रिसर्चर्स ने भी इसकी फर्दर क्लासिफिकेशन की लाइक द मॉर्गन एट आल ने एंड द मैफ्रिक एट आल ने फर्दर डिवाइड किया इनटू 10 डिफरेंट टाइप्स ऑफ स्लैब टियर पैटर्न्स और उन्होंने इसकी जो स्लैब टियर और बकेट हैंडल लेजेंड जो है इनके साथ साथ और बाइसेप टेंडन के साथ साथ उन्होंने इसमें बैंक कार्ड टाइप इंजरीज जो है जो इसकी नीचे वाले क्वाड्रेंट में इंजरीज यानी लेब्रम के नीचे इंजरीज है वो भी इसके साथ जो है एसोसिएट की है और वो फिर इन सब को जो है इन स्पेसिफिकली लेगमेंट्स इन्वॉल्वमेंट को लेगमेंट्स जो है ये इसके साथ इंजर्ड है या नहीं है तो इन तमाम को उन्होंने फिर फर्दर जो है इस तरह डिटेल से 10 डिफरेंट टाइप्स में डिस्कस किया है सो अब हम आगे जो है ये 10 टाइप डिस्कस करें इसमें से टाइप 4 तक तो वही स्नाइडर वाले हैं जिसमें से डीजनरेटिव चेंजेस विदाउट बाइसेप टेंडन इन्वॉल्वमेंट डीजनरेशन बाइसेप एंकर डिटैचमेंट हो जाती है पकड़ हैंडल टियर ऑफ द सुपीरियर लेब्रम बट द बाइसेप एंकर जो है ये इंटैक्ट रहती है पकड़ हैंडल टियर along with the detachment of the bicep tendon तो ये तो टाइप 4 ऑलरेडी हम डिस्कस कर चुके हैं व्हाट इज द टाइप 5 तो if there is a big clot lesion extension of this lesion it reach या it cross that quadrant ये नीचे क्वाड्रेंट में चला जाता है inferior and superior quadrant में चला जाता है so if there is extension of a big clot lesion with involvement of the superior labrum and bicep anchor or slab lesion with the interior and inferior extension then it will be called as type 5 so we can simply call as the type 4 plus the Binkart lesion, they will be termed as the type 5. In the type 6, interior or posterior flap tear similar to slab type 4 are 3 with a bucket handle environment. So यहाँ पे जो है flap tear जो है आ जाती है. This is the type 6. अगर यहाँ पे जो ligaments की involvement आ जाती है slab की, so then it will be termed as the type 7. So the extension of the slab region into the glenohumeral ligament and they will be termed as the type 7. And type 8 extension of the slab region into the posterior labrum and further abnormalities they will be called as the type. यहाँ पे बाकी जो type वहाँ पे स्पेसिफिक टाइप 5 पे इंटीरियर एक्सटेंशन आ जाती है टाइप 8 में जो है ये पोस्टीरियर एक्सटेंशन जो है आ जाती है सो इसमें जो रिवर्स बेंकार्ड रीजन है वो भी उसमें आ सकती है टाइप 9 जो है दिस इज circumferential labrum detachment which is overall labrum जो है ये डिटैच हो जाती है and type 10 type the last this is the extension to the rotator cuff interval and the articular-sided abnormalities. So अगर लेब्रम के साथ साथ जो है articular cartilage of the granite cavity ही भी involve हो जाती है और या जो है इसमें rotator cuff की tendon involve हो जाती है along with the slab region. So then it will be called as the type 10 slab region. तो ये 10 types थे जो मॉर्गन एट आल ने और मैफ्रिक एट आल ने जो है इनको डिस्क्राइब किया so this is the again the summary of all those type 10 type 1 there is only degeneration anchor intact होता है type 2 degeneration with detachment of the tendon type 3 bucket handle tear with the intact bicep tendon type 4 bucket handle tear with the detachment and the avulsion of the that bicep tendon and type 5 जो है this is the type 2 या we can say that slab lesion plus the brain cartilage and type 6 this is the type 2 plus the unstable flap type 7 this is the glenohumeral ligament specifically the middle glenohumeral ligament This is the type 7 and the type 2 plus the posterior extension. This is opposite of the type 5 where there is the anterior extension, and type 9 there is circumferential, and then the type 10 when there is the detachment of the biception along with the degeneration of the labrum, as well as there is uh, involvement of the posterior infection, or there is involvement of the that rotator cuff tendon or the articular cartilage or that reverse pericardium. So that all will be called as the type 10 injuries. So this is that circumferential. This is the reverse pericardial lesion. So that is the opposite. This is the opposite of the Pincott lesion. Pincott lesion is basically from the 3 o'clock position to the 6 o'clock position, and that is the characteristic injury of the anterior shoulder dislocation. While the characteristic labral injury is associated with the posterior shoulder dislocation, that is mostly the posterior labral tear, and specifically if it is present between the 6 o'clock position and the 9 o'clock position of this granite clog, so that will be called as the reverse ring cartilage. As we discussed, there is the complete detachment of the circumferential injury, and the type at this is the posterior extension. There is the slap lesion, and slap lesion के साथ साथ जो है यहाँ पे posterior extension आ गई है, so that will be the type 7. टाइप 8 टाइप 7 में स्लेप लेजन के साथ साथ यहाँ पे लेगमेंट जो है ये अगर इन क्लीनोह्यूमरल लेगमेंट इन्वॉल्व हो जाती है तो द एक्सटेंशन ऑफ दिस स्लेप लेजन द लेगमेंट क्लीनोह्यूमरल लेगमेंट विल बी कॉल्ड एज द टाइप 7 स्लेप लेजन. Type 6 when there is a unstable type is present along with the slap lesion, and type 5 we can see here there is a slap lesion plus there is extension to the anterior region. So यहाँ पे हम consider कर सकते हैं कि the slap lesion along with there is a Brinkart lesion as well. So they will be called as the type 4, and these are already हम previously discussed. Okay, so this is the 10 type classification of the slap lesion. अच्छा, इस इंजरीज की बारे में बात कर ले तो जैसे हमने पहले कहा था कि ये सिर्फ और सिर्फ जो है थ्रोइंग एथलीट्स यंग एथलीट्स में नहीं होती जिस तरह इनिशियली डिस्कस किया गया था, बल्कि ये डिफरेंट जनरल पॉपुलेशन जो है उसमें भी जो है पाई जाती हैं, जैसे लेबरर्स में भी हो सकती है और ओल्ड एज पीपल में भी हो सकती है. सो दैट इज नॉट ओनली द population that young throwing that they're having the slap lesion. There is increasing evidence that slap tears are frequently present on MRI and asymptomatic overhead athletes. जैसे हमने पहले डिस्कस किया था कि that is a debatable point कि if there is no such symptom but on the MR there is clearly slap lesion मौजूद होती है. So one of the answer to this query is like that. This may be that physiological adaptation to that overhead activity is specifically in the late guard position of that throwing, they are going to that extreme external rotation, and that may have some produce some tension at the on that bisection and on the labral, which may lead towards the slap lesion. Similarly, some researchers have been discussed that during the acceleration early after the late cock, there may be also having attention on the that labor tear, and this may be a reason and mechanism why there is slap agent present in the overhead athletes without any symptom. So thus clinicians should remain cognizant of the non-clinical ambiguity that may present with slap agent recognized isolation or association with other shoulder pathology. क्लिनिकली जो है हमें ये भी देखना होता है कि if there is asymptomatic. So we can't consider as a patient, though there may be a positive sign on the MR. जब तक उनकी क्लिनिकली जो है एविडेंट नहीं होता वो कंडीशन, तो उसके लिए जो है इसकी हम ट्रीटमेंट जो है जरूरत इसकी नहीं है। हाँ, इफ देयर इज की अगर उसकी एसिम्प्टोमेटिक है लेकिन उसके साथ साथ जो है उसकी जो थ्रोइंग वेलोसिटी, उनकी जो थ्रोइंग परफॉर्मेंसेस है, उनकी जो थ्रोइंग स्पीड है वो अगर डिक्रीज हो गई है, जिसका मतलब है स्टिल जो है the problem is present and it need management of that region. Etiology की बात कर ली, so there is not a single etiology and a single theory that will be responsible for the slave religion. It is a multifactorial and multiple uh, reasons they are just behind this slave religion. But regardless of the underlying lesion, patient presenting with the symptomatic slave tears, they will commonly report the acute onset of deep shoulder pain. And that is the main characteristic, as the pain is originating from inside the joint, from the labral attachment. So that's why the patient will train up that pain from the very deep of the shoulder joints, which will be accompanied by the mechanical symptoms such as the popping, locking, or the catching with various shoulder movements. And this is again another characteristic of this lesion, that there will be deep shoulder pain. The patients, the kids will just report that the pain is coming deep on the inside of the joint, and as well as they will be characteristic popping, locking, the catching as well. अगर हम इसमें इटियोलॉजी पर बात करें तो थोड़ा सा मैकेनिज्म पर बात करेंगे कि कौन से मैकेनिज्म जो है इसके इन्वॉल्व है। सो ऑन द बेसिस ऑफ दैट हम पहले एक्यूट ट्रॉमेटिक इंजरीज की बात करेंगे, फिर आगे हम एट्रॉमेटिक की भी बात करेंगे। एक्यूट ट्रॉमेटिक जो है इनकी ये तीन मैकेनिज्म हो सकते हैं, जितने भी ये मोस्ट कॉमनली होते हैं स्पेसिफिकली इन द वर्ल्ड एथलीट्स। सबसे जो पहले टाइप है of this traumatic slip injury, this is one is the compression type injury, the other is the traction type injuries, and the other is the combination of these two. So this compression type injuries that was initially described by the Snyder in their study, as his original case series from 1990 reported that about half of the patient presentation was status post fall and with outstretched arm, with arm in varying degrees of the shoulder retraction. और ये चीज जब ये fall and outstretched arm के साथ होती है तो उसमें एक लोड जो है आ जाती है और इसकी वजह से एक कंप्रेशन आ जाती है, and that exert load compression directly from that, जैसे जमीन पर गिरती है और आप हिट करती हैं जमीन के साथ, तो जमीन का जो इम्पैक्ट है ऑन द हैंड, that exert load they will be compression के तौर पर they will lead towards that injury in the slab. Traction type injuries, these are secondary to the certain jerky movements or after lifting heavy objects beyond the level and beyond the strength of the person. And then can occur after an unexpected pull on the arm as well, and obviously combined type injuries, and there is both the compression and traction mechanism involved. Now, what is peel back mechanism in the traditional slab injuries? In these scenarios, slab tears present with the insidious onset and progressive deep shoulder pain in young athletes with the arm in the abduction and external rotation during the late cut phase of throwing. जब इनकी ये पील बैक मैकेनिज्म इसलिए कहते हैं कि जब ये लेट की पोजीशन पे जाते हैं तो वहां पे ये एक्सट्रीम एक्सटर्नल रोटेशन भी होती है और ऑब्वियसली शोल्डर जो है 90 डिग्री एबडक्शन में, तो वहां पे इनका जो टेंडन है लॉन्ग हेड ऑफ द बाइसेप टेंडन ये ट्विस्ट हो जाता है। सही, और ये यहाँ पे हम देख सकते हैं कि ये ट्विस्ट हो जाता है जैसे ही वो abduction plus external rotation में जो एक्चुअली द मोमेंट इन द लेट का पोजीशन There is twisting up and as well as there is some stretching of this long head up bicep tendon और यही जो है इसकी रीजन हो सकती है डिटैचमेंट की और स्लैब लीजन।
और इसी पोजीशन में जब ये लेट कैकिंग फेज में चली जाती है, यानी एबडक्शन होती है और फिर वहां पे एक्सटर्नल रोटेशन इसके साथ ऐड हो जाती है, तो वहां पे जो बाइसेप है ये इस पर जो फोर्स आती है, क्योंकि ये फोर्स इसलिए आती है कि जब एबडक्शन होती है शोल्डर जॉइंट, तो ये बाइसेप जो है ये अदर मसल्स के साथ साथ एक स्ट्रेन है, इसको कंट्रोल करता है इस मूवमेंट को, तो इट इज अ डायनामिक स्ट्रेन ऑफ दैट एबडक्शन. So that's why obviously during scanning the abduction, there may be some tension and some force on the bicep. लेकिन इस पोजिशन में जब एक्सटर्नल रोटेशन जो है इसके साथ ऐड हो जाती है, तो फिर यहाँ पे बाइसेप फोर्स के साथ साथ जो है यहाँ पे पोस्टीरियर ग्लाइड है, क्योंकि there is external rotation जब होती है, there is obviously posterior glide of the humerus, तो ये उनके साथ जो है कंबाइन होती है और ये दोनों जो है the force on the bicep and that posterior glide of the humerus inside that glenohumeral gland, that then up the posterior superior quadrant of the granite and the posterior labrum. तो हम कह सकते हैं कि जो एक्सटर्नल रोटेशन है इस पेशेंट का ड्यूरिंग द थ्रोइंग मैकेनिज्म, दैट इज द काज इज, क्योंकि जब तक सिर्फ एबडक्शन होगी तो एबडक्शन में ये posterior glide जो है they will not accompany that force on the bicep tendon, there will be no such that twisting maneuver कि हम स्लाइड में डिस्कस करेंगे जो मैं कैरेक्टरिस्टिक ऑफ द स्पीड ब्रेक मैकेनिज्म है, तो ये एक्सटर्नल रोटेशन भी है एंड दैट इज द रीजन कि जितना एक्सट्रीम एक्सटर्नल रोटेशन और उतना ही चांसेस जो है ज्यादा होंगे. So slip lesion in the throats occur back mechanism, which is defined as the increased strain at the bicep tendon during the late cut phase at the maximum external rotation, as we discussed in the previous slide. This is one of the important dynamic strain against the external rotation, as well as when the arm is abducted. So that's why during that abduction and external rotation, this dynamic straining level some force and tension on the long head bicep tendon. And the increased incidence of the step in these ball features that support this feedback in this mechanism जो अभी already discussed कर चुके हैं. जहाँ पे दो डायग्राम्स आपके सामने आएंगी, पहला ऊपर के अगर अब हम देखें तो this is the resting position, this is the labrum, this is the labrum, and this is the long head of the bicep, the long head bicep tendon. ये इसके साथ attached, but when there is external rotation in the abducted arm, so there is twisting of this tendon, and this twisting there will the up that superior anterior superior region, and sometimes maybe the anchoring of that bicep tendon की भी जो है इसमें डिटेल्स हो जाती है. So that posterior rotation of the bicep tendon is the bicep anchor at the superior aspects of the labrum from the superior part of the granite. So this is that posterior rotation and twisting हम कह सकते हैं at the tendon, and which is up to the external rotation in the abducted arm. यहाँ पे रिसर्च के दरमियान मुख्तलिफ जो है रिपोर्ट आ रही है और contradictions है finding में. Some are supporting the feedback mechanism while some other are supporting that up to the late acceleration or acceleration के बाद जब deceleration होती है, तो that deceleration is actually responsible for the slab tear. अब जो feedback mechanism है इसमें usually जो phase involved होगी out of those 6 phases, late का phase involved होती है, जबकि दूसरी जो डिक्लेरेशन वाले में हम बात करें तो ज्यादातर इसको अट्रैक्शन बेस्ट टाइप मैकेनिज्म यूज होती है। जब यहाँ पे हाथ जो है एक देयर इज एल्बो एक्सटेंशन होती है, देयर इज एक्सप्रेशन, एक बाल रिलीज होता है और एक जर्क मोमेंट्स, दैट जर्की मोमेंट्स डेविड जिसे मैं यहाँ प्रीवियसली डिस्कस किया था कि when there is traction tapping there will be jerky movements up या are after the heavy lifting heavy objects। तो यहाँ पे जो deceleration जो सपोर्ट करते हैं कि प्रोएस में ये deceleration is actually the reason behind that slipping। So that is that simple that movements with the traction in the bicep tendon attachment version of this, not only the bicep long head of the bicep tendon as well as the superior labrum. And that interior superior labrum is actually damaged and injured just because of the tension on the bicep tendon. अच्छा, डीजनरेशन स्लेप जो है ये अमूमन जो है ओल्ड एज में ज्यादातर होती है एंड दैट इज normally that is not only the slave degeneration. Degeneration is a normal phenomena which occur normal से मुराद ये है कि एक ongoing process and inevitable phenomena है with the advanced age, like the other cartilage, like the changes in the vertebral column, like the degenerative changes in the cartilage, the degenerative changes in the ligaments, and there is also degeneration of the slave. The degenerative slave here are poor head laborers with increasing degradations and pressure which are specifically more than was up or put was on. There is another classification, and these researchers that describe the eight types, and mostly they are similar to the previous one. लेकिन यहाँ थोड़ा सा जो है उन्होंने कुछ एडिशन किया है, लाइक जैसे यहाँ पे हम टाइप 2 भी कह सकते हैं कि they are saying टाइप 2 most जो है ये and almost every time when there is the detachment of the long head of the bicep tendon is detachment routine, so it means there is some trauma involved. So that's why this is traumatic or this is very acute. So according to this classification, the type 1 step here is degenerative like the all other classification. There is degenerative occurs at the edge of the labrum and insertion to the nerve may check as it's common to all other types. And the type step here, it is most acute, and the labrum and the long head bicep tendon, they are torn and revulsive of the benign cavity. The avulse area is now divided up the cartilage in the zone of injury. The type 2 is the bucket handle, and this is the rarest form, the bucket handle here, and the labral insertion of the long head of the bicep tendon is lip and abdomen. And the type 4, which is the extension of the type 3, the type 3 plus interior shoulder instability are that, and this is the new point which is added to this classification. That type 3, there will be interior shoulder instability. Plus, you can see here here again there is involvement of the extension to the long head of the bicep as well. So this point was discussed in the previous classification as well, but in this they have discussed, they have added the anterior shoulder instability as well. Often seen in situation with the shoulder instability and anterior labral tears. Type 5 when there is anterior shoulder instability are, as we discussed previously, that the characteristic labral lesion of the anterior shoulder instability of the anterior shoulder dislocation is the wing cord lesion. So the type 5 fracture is that type of fracture, and when there is extension to the interior and anterior quadrant, when there is interior extension, or simple words, we can say that when there is wing cord lesion along with the slab, it is the type 5 slab. The type 6 slab fracture pattern involves larger superior level crabs without detachment of the long head of the bicycle insertion. So यहाँ पर भी type 2 and यहाँ type 2 type 4 फर्क जो है यहाँ type 6 में long head of bicycle रहेंगी. They have discussed that it is without the detachment of the stem. In the type 7 step here, this is equal to type plus the middle and inferior neural ligament compromise, while in the previous one they have discussed mostly the middle one. Here, pattern seen instead of complete stability presentation. In type 8, here plus an additional cartilage just into the bicycle foot band. So these were the 8 types which were discussed by researchers. So एक तरफ अगर देखा जाए तो बहुत सारी चीजें जो इसमें कॉमन से आ रही हैं. So if it is the type 4, if it is the type 8 classification, it is the type 10 classification, all of them they are equal that the step region there is degeneration, detachment of the line of biception, there may be there may be extension to the interior quadrant, there may be extension to the posterior or the posterior inferior quadrant, there may be involvement of the complete level, and as well as there may be some involvement of the articular cartilage as well as the rotator cuff. अगर हम इपिमेलॉजी के बारे में बात की तो इस इंसिडेंस के बारे में लिटरेचर बहुत कम है, और एक वजह ये हो सकती है कि सम टाइम जो है इसकी इस डायग्नोसिस लुक हो जाती है. जो फिजिकल थेरेपिस्ट है, फिजिशियंस हैं, जो ऑर्थोपेडिक सर्जन है, ऑर्थोपेडिक डॉक्टर्स हैं, when they are assessing the shoulder pain, most they overlook this step vision and get for some other diagnosis, and hence it is not reported, and that is one of the reason it's that incidence is less reported. On the other hand, literature is also very rare on this incidence of the step vision. Furthermore, the respective incidence rate for the clinical diagnosis of slave vision and the incidence of slave repair remain limited to the net paucity of the available high quality studies. Paucity, you can say it may lead towards the rarity or the unavailability of something. Available epidemiological data and surgical management trends. So हम यहाँ पे incidences की estimate लगा सकते हैं. That might just the how many people they have received the slave repair. तो मैनेजमेंट इन लोगों ने की है, उसकी रिपोर्ट थोड़ी बहुत जो है मिलती है, और इसमें सर्जिकल रिपेयर उस पर उससे अंदाजा लग जाता है कि if there is too much slave repairs in there is increase in incidence, and if there is this cases to maintain the less incidence of the slave tourism. Similarly, 2001 तक के लिए एक separate intestinal disease के तौर पर इस इंजरी के तौर पर इसके लिए कोई बोर्ड इंटरनेशनल क्लासिफिकेशन ऑफ दैट जो है, जो इसका मॉडल है डिसेबिलिटी मॉडल ICF, वहाँ पे इसकी कोई बोर्ड नहीं था, और फिर जो है 2003 में जो है इसको एक्सिपरेट टर्मिनोलॉजी मिल गई, और कोड इसका जो मिल गया दैट वाज द 29807. Highest एक research के मुताबिक the highest incidence rate of slave vision was present in the 20 to 29 year old and 9 years old age groups. Or mostly 20 to 29 years old, and these are the athletes, or 9 years old, these are the laborers. while there is जो 30 और 40 के दरमियान होते हैं, तो यहाँ पे एक तो डिजनरेशन की गई कि थोड़ी अर्ली है, और मोस्टली जो है जो प्लेयर्स होते हैं वो 30+ में अमूमन जो है रिटायर्ड हो जाते हैं इसके पिक्चर, क्योंकि उनकी स्पीड और परफॉर्मेंस नहीं होती. तो दैट्स व्हाई इंसिडेंस जो है इन डिकेड में जो है इसमें कम है एज कंपेयर टू द दैट 2029 and slave pigeons. They commonly occur in the estimated overhead athletes, and that we have discussed in the previous day as well. Still, there is a question that if it is an ingredient, there is such a disease, such an damage to the tendon of the bicep as well as to the posterior labrum, then why there is no why there is asymptomatic, why there is no such pain or other sounds like which are the characteristic of the slave region. Many MLB, which is including the major ball that is the sports playing at the US, the team position now recognize this asymptomatic youth as their adaptive changes, high level exposure towards in the MLB pitches. There was a rise in the in that slab rates, and that was greater than 10% of the sugar cases reported by the year 2008. Original slab repair में जो increase आया था, तो इससे उन्होंने एक estimate लगाया कि the incidence of the slab region is increasing from 2002 to the 2008 or 2010. दूसरी स्टडी की गई 2012 में, उन्होंने भी जो है यही रिपोर्ट किया कि जो आर्थोस्कोपिक स्लैब वेयर हेड से सिंपल न्यूयॉर्क स्टेट में, नेट सिटी में, न्यूयॉर्क स्टेट में, वहाँ भी देयर इज राइजिंग, और राइजिंग कितनी, जब 2002 से 2010 तक उन्होंने जो डेटा दिया, वहाँ पे देयर वाज 464% increase in the number of slab. This is not a small amount, small figure. This statistic is huge difference. That is a not 100%. This is more than that. It's 464% increase as compared to the 2000 in comparison of the 2000 and 2010. This increase constitutes a jump in case volume from the 65,330 inward slab repairs. This increase translated to a population-based increase incidence rate from 4 per 100,000 patients in 2002 to 22.3 per 100,000 patients in 2002. The initial rise in the incidence rate of the slab repair executed and they reached peak growth of declining for the last decade. Moreover, clinicians began reporting on the clinical importance of initiating younger patient population which are under that 40 years old and who are related from the older patient which is plus a degenerative step resulting to the repeat overhead in manual labor occupation. A study published in 2015 investigated the adjusted incidence rate of slave here as reported in the Defense Medical Epidemiological Database between 2002 and 2009. The adjusted annual incidence rate for the slave region increased from 0.31 cases per 1,000 person in 2000 to 1.88 cases per 1,000 person in 2009, with an average annual increase of just 20% during the study. Still, this is a we consider at that point the 1,000 and inside 1,000. This is the huge difference between 0.31 to 1.88. Sleep accounts for 80 to 90% of the regular pathology in the stable shoulder, although they are typically seen associated with other shoulder pathologies and rarely present in isolation. Furthermore, slab tears account for approximately 1% of injuries present in the sports medical referral centers, and slab tear are present in approximately 6% of shoulder. Now let's discuss the pathoanatomy, specifically that IGHL as well as the long head of the bicep tendon ankle. In third slab may be due to the tightness of the posterior IGHL, which shifts the humeral contract point posteriorly and increases the shear force on the superior labor. Slab region increases the strain on the interior band of the digestion and thus compromises stability of the shoe. There is a variation in the anchor anatomy, and not only in the bicep anchor, but in the tendon's origin as well. And that translates to varying levels of strain on the superior level. This variation translates a varying level of strain on the superior level. Banksness et al. Initially described four types of attachment pattern of the long head of the bicep tendon to the superior grenade rim of the superior level. So Banksness ने चार टाइप डिस्कस की कि लॉन्ग हेड ऑफ बाइसेप टेंडन जब अटैच होता है वहां पे labrum appears to be in the superior grenade rim and as related to superior labrum. चार subtypes थे. And these four types were described are based on the 105 cadaveric shoulder specimens and above and among 105 22% the attachment of that long head of the pulsar tendon was attached posteriorly and there was completely on the posterior side. 33% ऐसे केस थे जिसमें posterior kidney and somehow interior attachment थी, लेकिन ज्यादातर इसकी attachment that was posterior. Posterior से मुराद ये है कि वहां पर जो pelvic position है, which is the that superior grenade work, वहां पे that point जहां पे is attached, it is known as the pelvic position. तो अगर वहां से ही posterior ज्यादा अगर attach है और less is attached to the anterior side, that was 33%. Here is equal attachment of this tendon on the grenade vertical interior and posterior that vertical. 37% cases here there was equal interior and posterior attachment. The rarest form was completely the tendon was attached interior that on the tubercle and interior to the tubercle. And there was no such fibers attached. There was the rarest form. Here is another classification of this attachment of describing this variation of the attachment of this long head of the chin. In a study which was based on the 100 shoulder cado specimens, the attachment site were quite different from the previous grid, and among according to them, the posterior complete attachment was 28%, the posterior dominant was 6%, and the equal interior and posterior equal attachment was 16%, and interior complete was 0%. The last interior complete was similar to the previous one, but the difference is in the equal. Here, the equal interior and posterior equal attachment is on the third position, while in the previous study, that was the most common type. Meaning that 37% of the 105 cases there were equal attachment on the dead point. अब आते हैं towards the next topic, which is the sub-labral condition. इस स्लेब के अलावा और कौन-कौन सी जो है लेबरिंग की पैथोलॉजी. So another potential predisposing certain patients to slab here is the presence of a sub-labral vesicle. Needles से मुराद यहाँ पे ये है कि ओरिजिन यानी जहाँ से ओरिजिन होती है स्लेब वेसिकल जो ओरिजिन होती है वो इस सब लेबरल ब्रेसेस की वजह से या सब लेबरल है. So actually the reason, the starting point जहाँ से स्लेब रूल हुआ था, the main reason, starting reason that इसको needles कहा जाता है, and that was the sub-labral braces, also known as the sub-labral circus, which is equally the tubercular position. The races of the circus can be present during the fetal development as early as by 22 weeks in the pregnancy, persisting throughout the childhood and into the adulthood. In contrast, a sublabral hole, sometimes in the research it is being termed as sublabral foramen, that is typically located at phylloplug 2 plug and is the anatomic manifestation of a congenital failure of the function of the labrum that attached to the denied with a smooth margin or immediate. There is another lesion of this labral lesion of this labral lesion known as the Buford complex, and this is a congenitally absent anterior superior labrum plus a thickened cord-like metal meningeal ligament. So these are the labral lesions. You can see here this is the sublabral foramina, which is between the trabecular position and the tubular position. Here it is from that trabecular position that near this tubular position, beyond tubular, and it is earlier to the tubular position. So that is opposite of the wing cord region. Wing cord region is from tubular position to sixth cord. This is a sublabral region, and then the complex. There is complete absence of the that labrum between the one of the position and three here between the trabecular position and the three position, the superior to inferior quadrant. This subdelta foramina and this one both are in the superior interior quadrant. If it divides, this is the superior interior quadrant, this is the posterior quadrant. So these both are in the superior interior quadrant. Alpenteki et al. Previously demonstrated that the tendon of the long head of the bicep contained a complex network of sensory and sympathetic nerve fibers. जब उन्होंने इस चीज को उन्होंने माइक्रोस्कोपिक स्टडी किया तो इनको पता चला कि यहाँ पे जो टेंडन है लॉन्ग हेड का बाइसेप का इसमें बहुत सारी सेंसरी और सिंपैथेटिक नर्व फाइबर्स. Previous reports have emphasized the long head of the bicep tendon as a potentially dominant source of anterior shoulder pain. जहाँ पे sensory nerve endings ज़्यादा होते हैं, that's why that is a dominant source of anterior shoulder pain and the clinical presentation. The Busmuller demonstrated via the immunohistochemical staining that there is an inhomogeneous distribution of nerve endings and sympathetic nerve fiber throughout the superior labral complex. The previous study they were just stating the presence of that sensory and sympathetic nerve fibers in the non-head of the bicep tendon. But this study, the Busmuller, they were stating that the superior labral complex they also contain the nerve ending along with the sympathetic nerve fiber. Interestingly enough, the interior aspects of the superior labrum and the labral region interior to the non-head of bicep has the highest density of these fibers, and that's why the patient most the pain of the dominant pain on the interior side. That may be the reason. This factor may have a potential impact on the patient experiencing persistent pain following the various type of slab repairs. Now, the history and physical examination of the slab region. So, when there is a patient in clinic with that shoulder pain, obviously we will have a comprehensive history. We will have a thorough examination, a subjective examination. When you are evaluating that patient with chronic shoulder pain. So we have carefully evaluate and assess that patient to differentiate and to remove or we can say that to rule out some conditions and to rule in other conditions. Slab tear may present in a relatively non-specific patient and association with other shoulder pathologies. Clinician should inquire regarding the certain elements in history that may help share slab tear from the other shoulder injuries. Pertinent elements in the history taking best elucidate the nature of potential slab tear or other shoulder elucidates the meaning to make it clear, to make it explicit, and pertinently the important one, the most the major points. So those elements in this help in the clear understanding of this nature of the potential that they will like the acute onset of deep pain and predisposition. Mechanical symptoms like the popping, locking, catching, various movements of pain. And mostly these two are the common symptoms in non-sleep. Each pain is sudden jerking towards the shoulder within sweat onset of pain. This is like the mechanism for the traction type of injury. History of current episodes of shoulder instability is again that iliac mechanism, which is in the abduction and external rotation. The history of are the current sports specific participation and which sports they are playing. So they will also help the therapist to decide and they will give some hints making the diagnosis. So including the level of competition that he is playing at the he is a recreational athlete, he is a collegiate player, school level player, or he is an elite player at high level, at the national level, or at the club level, the professional athlete. So this is very important because the level of competition, they will also they have some impact and influence on the activity and that stretching and the range of motion being used during that sport. Common slave boating sports include, but are not limited to overhand sports like the volleyball, like the baseball pitcher, like the javelin throwers and the swimmers. History of current manual physical labor occupation. Characteristic of the long head bicep pathologies may include any combination of the following that may be their most air traumatic and status onset of the anterior shoulder pain, symptom exacerbation with overhead activity, pain radiating down the anterior arm from the shoulder, clicking or audible pulse reported in the setting of proximal bicep stability and pain at rest, pain at night, or present. Now, there is also a comprehensive examination of the surrounding region as well, like the cervical spine, the neck spine, the neck examination, as well as the thoracic. The coexisting cervical radiculopathy should be ruled out in these cases. The rear neck and shoulder pathologies are in consideration. Observation of neck posturing, muscular symmetry, palpable tenderness, and active passive range of motion should undergo evaluation. A special test which can help us to rule out the cervical radiculopathy, that is the Sperling maneuver, as well as there is myelopathic testing and a comprehensive neurovascular exam. So this is the physical exam. This is the Sperling test, sometimes also known as the foraminal compression test or the neck compression test, also known as the quarter test. And the procedure is that you will be extending the neck, then there will be rotation of the neck, downward pressure on the head is applied, and positive findings elicit the reduction of radicular pain into the ipsilateral arm of the head rotation. While uh, the same maneuver, if it is applied to the opposite side, so somehow they will maybe repeat in the symptom in the opposite side. That's a very good test as its sensitivity is 92% and 95%. Sensitivity means the rate of true positive and specificity means the rate of true negative. Sensitivity means the true positive divided by all the disease public. They will give us to the sensitivity. And if you want to calculate specificity, so that is the true negative divided by all the healthy people, they will give us the specificity. So both of them, they are over 90, so we can say that that has uh, somehow good diagnostic index or diagnostic report. Low sensitivity but high specificity, not useful as a screening, but it does help confirm the diagnosis. Still, it is considered as good. It is not that low sensitivity. Still, there is 8% deficiency, but still it is good than many other tests which are having the sensitivity less than 90%. The next is to comprehensive examination of the shoulder and to rule out other conditions of the shoulder. So examiner should observe and compare the bilateral shoulder girdle and just to assist any asymmetry, specifically in the top of the shoulder and in the asymmetry at the inferior angle of the scapula. The distance between the inferior angle of the scapula and the uh, minus versus of the vertebra. So this distance should be made on the both sides and should be compared. Similarly, there should be observation of the positioning, given there is elevation of the shoulder. Is there earlier movement at the scapula? Uh, is there any movement of the scapula earlier than the 60 degree elevation? Or in there is elevation of the shoulder more than 60 degrees. So there is movement, there is upward rotation and interior rotating of the scapula. So that should be observed. Similarly, in that area, in the shoulder area, in the shoulder complex, there should be preparation for the muscle pull, and there should be comparison in entropic changes. And both side comparison, that's very necessary, and that should be checked for the entropic changes as well. The skin should be observed for the presence of any previous surgical incisions, lacerations, scars, erythema, or induration. Induration means the hardening of the tissue, and the erythema simply means the redness in the skin. Chronic instability patient will almost always exhibit at least the mild asymmetry, and the tight muscle upper state for the chronic dislocation because of the injury of that nerve which is supplying the auxiliary nerve which is supplying the motor supply to the auxiliary to the tight muscle. So mostly they may atrophy in the anterior shoulder dislocation. Findings can be rather subtle, especially in these patients. If there is anterior shoulder dislocation, then there may be presence of a palpable anterior fullness, and upon observation, the posterior shoulder, when viewed from the side of the patient, will be relatively flat relative to the fullness. Tonic anterior and posterior stability patient may also exhibit corresponding posterior and interior abdominal prominences. So this is actually the characteristic sign of a patient with anterior shoulder dislocation. They will be prominent cranial. They will therefore be better detailed somehow say that a square shoulder here. On the other side, if you look at this side, here is a round shape, there is a dome shape up there, deltoid round shoulder, but here there is a corner. That is actually known as the square shoulder. Uh, top, this is there is flatness, or you can say that the atrophy of the entitlement. This is their interior fullness, and the arm will be slight abduction as well as slight internal rotation as well. This is the interior stability specific position clinical appearance of the patient with the their interior stability or the anterior shoulder dislocation. There will be prominence of the acromion process. Shoulder will threaten just because of the deltoid atrophy. Even the head will be prominent. They will slight abduction plus they will be fixed and they will be internal rotation and uh, supported by the other hand. This is the normal hand, it will support this hand. This is the reduction of the interior dislocation of pinea hand by hanging weight in the wall side, the recovery and the reduction of the dislocated shoulder joint. Similarly, and the anterior radiograph, um, they will subguide dislocation. Simply that dislocation that the head is just below the subcoracoid. Then, if there is anterior shoulder instability, or here is the anterior shoulder dislocation, so it should be categorized as the TUBS or EMRI. TUBS stand for the traumatic unilateral cartilage surgery. Mostly it is happening in the athletes when it is acute and traumatic. So that is obviously trauma is on one side and it is so powerful and so in a high energy trauma that it may lead towards the Bengard region extension to the Bengard region again, and obviously surgery is the rare treatment of the appropriate option of treatment for this type of injury. In the EMBRI, the A stand for the atraumatic, the M stand for the multi-direction. In the acute case, when it is that mostly it is in the unidirectional, that depends that what was the direction of the force. The B stand for the bilaterality, mean commonly that the atraumatic or the chronic case, they will present on the both sides rather than immediate. And mostly they will good response to the rehabilitation, they will positive response to the rehabilitation, and the I stand for the intensive rehabilitation. Scapulothoracic motion of the scapular and scapular wing, they should be elevated. If there is any scapular wing, if there is on the observation, there was prominence of the inferior angle of the scapula, it can be termed as the type 1 shoulder disc angle. If there is prominence of the entire medial border, which may be associated with the long head of the long thoracic nerve injury, and that may be because of the weakness of the serratus anterior, and that may get termed as the type 2 scapular disc aneurysm. If there is prominence of the top of the scapula, that may be due to the disturbed ratio between the strength of the upper trapezium and the lower trapezium. And the type 3, mostly there is imbalance ratio between the strength. There is overactivity of the upper shoulder, upper trapezius, while there is weakness in the lower trapezius. So when there is upper overactivity, it means they will be too much strong and tight, while on the other hand, they will weakness in the lower trapezius. This imbalance between the strength of the upper trapezius and lower trapezius, that will lead towards the prominence of the superior portion of the scapula, which is called as the type 3 reciprocal disc aneurysm. This classification is the classification based on the Kibler, also known as the Kibler classification of scapular disc aneurysm. Following the observational component of the physical examination, the both active and passive range of motion they should be measured and should be documented. This may be limited in the setting of initial follow-up in the clinic after acute instability or the setting of any complex instability case, specifically in the setting of the delayed bone loss. In the setting of the chronic anterior instability, the clinician should attempt to assess the current status of the axillary nerve. As this is very important, as this is the same nerve which we discussed previously, important for the motor supply of the deltoid muscle. And if there is normal deltoid function and with normal strength, so it may indicate that there is no sentiment to the axillary nerve. Similarly, we should also examine and evaluate the strength of both the internal and external rotator of the shoulder. The internal rotator of the shoulder is the subscapularis of the rotator cuff, while the external rotators of the shoulder, they are the teres minor and the infraspinatus of the rotator cuff. Specific testing of the supraspinatus muscle can be in passive range of motion limited. Any evidence of significant muscular weakness and get an underlying neurologic. A detailed sensory examination should take place in all, including body stability patients. In addition to axillary nerve function, motor function of the elbow, wrist, and hand should undergo an assessment to rule out the possibility of a brachial flexion with the shoulder dislocation. Distal pulses at the wrist they should be assessed, as well as the older patients, and in the setting of suspected intermittent shoulder pathology, they should be evaluated, like the cuff, the bicep tendon pathology, and specialized testing should be rule in order to rule out these pathologies. Now, some of the special tests which can be used during the objective examination and during the provocative examination. And the available evidence of the level 1 and studies, the recent literature suggests that a combination of the specific, such as the speed test and the upper cut test, is recommended for the clinical detection of the bicep tendon lesion. Many others tests they have been reported in the literature for the bicep tendon pathology, bicep tendon lesion. Recent studies have reported on the diagnostic inquiries of specific tests concerning the diagnosis of the and these are the different tests which have been reported in the literature. These are tests they can be used to assess the pathology of the bicep tendon. Among the most common are the Lesion test and the speed test. The other tests which can be used for the bicep tendon pathology, these are the non-specific bicep tendon test, the Ebert Saunders test, the SNAP test, the Hilter sign, the Ludington's test, Littman test. And the speed test, it has very, very low sensitivity of 32% and specificity is 75%. A positive test consists of pain elicited in the bicipital groove when the patient attempts forward evade and the therapist will provide the resistance to that evasion, while the other hand will just beyond the that bicep. If the patient reports the pain at the bicep, there will be a positive sign. This is the uppercut, which is most commonly in the boxing competition, that is known as the uppercut, and hitting the opponent jaw from that below direction in the upward, that punch from the low side in the upward direction toward the chin, that which is called as the uppercut punch. So this test, because of the same activity, this test is known as the uppercut. That sensitivity is better than the previous one, a speed test, and this is 73%, and specific is also the best, as there was the specific was 75%, and it is 78%. Involved shoulder is positioned at the neutral at the hip is fixed to 90. Forearm is supinated. Supinated. Supinated means the palm will be directed towards the ceiling, and then the patient make a twist. The examiner instructs the patient to perform the boxing uppercut punch while placing his or her hand over the patient's wrist, and not only placing but also provide some resistance to the upward movement. A positive test is pain on a painful pop toward the anterior shoulder near the bicep region. So during this movement, the therapist will resist this movement, and if there is eliciting a pain, there is pain increasing in intensity at the bicep region, that may indicate the positive test for the bicep. And the irrigation test, its sensitivity is also less than the previous one, but good than, better than the speed test. Its specificity is better than all the previous tests, 79%. The arm is stabilized against the patient trunk. There is no such abduction. And the elbow fixed to 90 is 90 abduction with the forearm united. As we can see here, the hand, the palm of the shoulder is in that direction. And here is the pronation of the hand. The examiner manually resists the supination while the patient also extends the rotate the arm against the resistance. So in the resting position, the patient hand will be in the pronation, and the therapist will try to make the hand in supination while the patient will resist this movement. So the therapist will want to have a supinated hand, and the patient will try to resist that movement and to keep the hand in the pronation. A positive test is noted if the patient report pain or the bicipital or the subluxation of the head of the bicep tendon. As we know that the bicep is also a good supinator, so during their resisted supination, if there is any problem with the tendons, it will have some pain at the bicipital. The beer hug test, And sensitivity is good 79% as compared to the previous studies, but specificity is less than the previous two tests. The patient places their hand on the contralateral normal. This is normal for the. This is the test which is going to be examined. So the patient initially will they will place their hand on the contralateral shoulder, like in a silver position. The palm is on the interior aspect of the contralateral shoulder with the elbow fixed at the 90 degrees. The examiner applies a perpendicular external rotation right at the left patient's hand up to the shoulders. A positive twist results when the patient cannot hold the hand against the shoulder as the examiner applies an external rotation. Billy press test, which is a good specific test, but its sensitivity is less. In this Billy press test, the examiner has the patient's arm at the 90 degrees at the elbow flexion, and there is internal rotation. It means when the arm is towards the belly, so obviously it will be the internal rotation, and if it is away from the belly in that direction, so it will be external rotation of the shoulder. At 0 degree, or we can say that the neutral. So, the therapy, the patient will press his or her arm against the belly, and the examiner initially support the elbow, and that uh, therapist is supporting the elbow. And a positive twist occurs if elbow does not maintain this position upon the examiner removing the supporting force. The next is the O'Brien test having sensitivity of 38% and specificity of 61%. The patient in the standing position and the arm of interest is positioned with 90 degrees of forward flexion, 10 degrees of the horizontal adduction, and internally rotated so the thumb point towards the. If the thumb is directed towards the ceiling, it is external rotation of the shoulder. The examiner places his or her hand over the patient's elbow while instructing the patient to resist the examiner downward force applied to the arm. Here are two tests of this maneuver, which we can regard as the O'Brien A test and O'Brien B test. This test is also known as the active compression test. In the maneuver A, the patient's arm shoulder is in the maximum internal rotation. This is the thumb. This is in the downward direction toward the ground. There is a 10 degree reduction as well as there is a 90 degree up flexion. And the therapist will apply a downward force, and the patient will resist. On the other hand, in the type B, there will be maximum external rotation at the shoulder, and the other hand, same, that is 10 degree of reduction and 90 degree of flexion. So this during this movement, what will be the positive sign? When will be the positive sign? A positive twist is denoted by the pen located at the joint line during the initial maneuver, thumb down internal rotation in conjunction with the reporting movements or elimination of the pen during the subsequent maneuver, palm or external rotation. So यहाँ तक जितनी भी हमारे टेस्ट all are the provocative examination. The provocative examination means during this moment there will be increase in the intensity of the pen. Then it will help us that here the pen is at which side, what is the location of that pen which is being up with the test. The next text is the interior slide test, and its sensitivity is very less 8%, while specific somehow good, that is 82%. In this case, the patient stand with his or her hand up and ball and place on the hips lateral, hip with the thumb pointing posteriorly. Thumb, you can't see the thumb as the thumb is present at the back. These are the digits which are present at the posterior, at the abdominal area. There is the hand is placed in the hips lateral. If we are assessing its right side, so the hand should be placed at the right side, hip joint or hip. The examiner places one hand on the joint line of the shoulder. This is the joint line of the shoulder and the other on the elbow of the patient. Examiner then applies an axial load. The axial load pulls that net cavity in anterior superior direction from the elbow to the shoulder. A positive distribute pain or a pen flick on the anterior joint line. This is another twist supine resisting twist. The patient lies supine on the exam table with his or her arm resting in full elevation with the palm and hand supported by the table. The palm is pressing upward and its sensitivity is 80% and speed is 9%. In this test, the examiner applies a downward resistance for just the elbow. Just this is the elbow, this is the proximal to the elbow, this is just the elbow. So it applies a downward resistance for just to the elbow while asking the patient to perform a throwing motion. So the patient, the therapist will apply a downward force while the patient will try to rise the sand and like used in the throwing of some subject area, throwing activity. The test registered positive only if the illicit pain deep inside the shoulder joint or at the shoulder dorsal respectively along the joint line during the resisted movement. Execution of the test on the unaffected shoulder should not elicit any pain. So that's why again there is should comparison with the other shoulder. The next test is known as the Myshire test, also known as the modified or Driscoll test or the modified dynamic test. A sensitivity is 80%. In this test, the patient stands with his or her involved arm, flex 90 degrees at the elbow, and abducts the shoulder in the skip of the plane with a row 120 degrees. Examiner then applies terminal external rotation until resistance is appreciated. After that, the examiner applies a shear force, and that's why it is known as the knife shear test. A shear force through the shoulder joints by maintaining external rotation and horizontal abduction and lowering the arm from 120 to 60 degrees of abduction. A positive test includes a reproduction of the pen and a pen click or cage in the joint line along the joint line 120 and 90 degrees of abduction. This will be discussed in the next session about the discussion of the radiographs, discussion of the MR, discussion of the CT scan. After that, we will also discuss the prognosis, the management, physical therapy management, the surgical management, as well as we discuss the complications and the post-operative rehab for the patient with that slab repair. Thank you so much, Father. Have a nice day.